A very good afternoon to one and all. I am Arpita from the IGCP group, today's moderator for the session on the topic cognitive dysfunction in diabetes. And to address the topic, we have with us someone very eminent from the field of diabetology, and other than Dr. Anil Varaskar, sir. It's a huge opportunity for me to welcome sir to this platform and to introduce him to everyone. So, sir has done MBBS, then MD. He is a consultant diabetologist at SL Raheja Hospital, Mumbai. Sir has more than 32 years of experience. He has many papers and publications to his name in national and international journals. So, sir, with this very brief introduction of yours, I would now request you to please start with the topic for today, and I will share the PPT.
Thank you very much. It's an opportunity to express my, deep study on this subject because it matters a lot when we are dealing with people with diabetes. You see, cognitive functions in diabetes are affected and it can make a lot of problems. First of all, the management of such patients with the impaired cognitive function really disturbs the normal skills and the control of blood sugar. Next slide, please. So I'm going to introduce the cognitive dysfunction in patient with type 1, in type 2, and what is the pathophysiology, and the clinical features and management, and then we'll give a take-home message. Next slide. So it's a less addressed and not yet well-recognized complication of diabetes is cognitive dysfunction. We have started realizing that this is a major hurdle in many areas where cognitive dysfunctions play a major role in formulating the line of treatment. Patients with type 1 and type 2 have been found to have cognitive deficits that can be attributed to their disease. Diabetes is associated with accelerated rate of cognitive dysfunction and increased risk of developing dementia. And this is a major health hazard which has got a lot of repercussions in your day-to-day life, interpersonal relationship, your performance at job, performance in school, and dementia, unfortunately, once develops, has very little pharmacological intervention treatment. Hypoglycemia as well as hyperglycemia means low fuel as well as excess fuel have been implicated as a cause of cognitive dysfunction. In fact, Alzheimer's disease is called as type 3 diabetes. Next slide. You see, number of people living with dementia across the world is increasing due to aging population. Age-related dementia is very common. If a person at the age of 75 has impaired cognitive function, we don't say that he's got Alzheimer's disease. Alzheimer's disease is characteristically seen in the people below the age of 45. It's a young dementia. Elderly dementia is not Alzheimer's disease. It's a senile dementia. So in Asia, about 23 million, and by 50, it will be 67 million who will have dementia. Next slide. 70 to 100 million people have Alzheimer's disease. 30 million people have dementia due to Alzheimer's disease, and 47 million are due to Alzheimer's disease in aging population. It's not really Alzheimer's, it's senile dementia. Next slide. So, what are the cognitive dysfunction type 1? Let's see. Next slide. Type 1 diabetes is very typically seen. If you take the history, the child is brought to you in your clinic, he says he is not attentive in the school. When the teacher is teaching something, he is looking at the teacher and not to the blackboard. Maybe the child finds teacher more attractive than the blackboard. But there is a slowing of information processing. There is a diminished psychomotor efficiency. There is a reduced attention span, and therefore diminished learning, and the problem solving aptitude goes down, the motor speed is slowed down, and the vocabulary is limited. The general intelligence goes down, and visual constructions are not able to be understood or performed again. There is a loss of motor strength, there is a reduced mental flexibility, and he is not able to function properly. Now, this is really interesting that all these features are immediately reversed once that HbA1c starts coming down. The child sugars are well controlled. You will see immediate results in his grades, his performance, his psychomotor school. You see, learning is a very complex act. Learning means first it should be registered. The information must go to your brain. And then once it goes to the brain, it is processed. And then it is registered in the form of a memory, is a form of a protein. That registration, once it is stored, it should be recalled. Recall is also part of memory. You should be able to remember it and act accordingly. All these components are affected because of the high blood sugar. Next slide, please. This is a very complex problem. And therefore, patients with type 1 diabetes, the deficit in cognitive functions have been detected as early as second year. The age of onset of type 1 diabetes may also contribute to presence of cognitive dysfunction. Higher the age, worse is the prognosis. Impaired executive skill, attention and processing speed. Intact executive skill, attention and processing speed after the age of 4, but the recall is poor. Next slide, please. Now you realize diabetes control and complication trials, HbA1c less than 7.4 performed significantly better on test of motor speed and psychomotor efficiency. While Brandt et al. Found that cognitive functions may be worse in patients who experience other diabetes complications. If the patient got nephropathy, if the patient has got some kind of vasculopathy, the dementia becomes worse. Next slide, please. Now, Ferguson found the proliferative retinopathy is associated with decline in cognitive dysfunction. Sure enough, if the vision, which is an important input to information, is impaired or affected, the child is not going to register the process of information. Therefore, retinopathy will worsen the process of learning as well as process of recall. Macrovascular complication, hypertension, and duration of diabetes were associated with decline in cognitive dysfunction. So, what decides is not only sugar, but hypertension and other vessel abnormality. Next slide. Now, with type 2 diabetes, what you see? That cognitive domains that have been found to be negatively affected is memory, psychomotor speed, execution of actions, processing speed, complex motor function, verbal fluency is lost. We should fumble for words. The fumbling for word is okay because you know too many words, you don't need appropriate word. You're not very happy with the right word, People who are playing Kaun Banega Karorpati, you'll see, you need absolutely full attention and apt word. And there is a reduced attention. The patient is not attentive at all. When you're even asking a question, does it hurt you? Do you have a tingling and numbness? Do you have any loss of power in the hand? He's not attentive. He answers vaguely what this fellow is asking. Why? I got sugar, you should control it. He is not paying attention to you at all because he does not give priority to this. And there is an element of depression. Now, please remember, depression is a very common problem in the society, particularly in the urban population. Almost 30 to 40% people are depressed. They may be depressed due to various reasons. The geopolitical scenario, the financial problem, the rush, the traffic jams, the children not performing well, deranged interpersonal relation, extramarital affairs, loss of money, loss of traders who have tried to take big risk, and the big risk is associated with the loss of money. So loss of money can also be a cause of depression, and many people don't come out that I am depressed. They don't like to accept this fact. And many vague symptoms that you see in private practice, the very vague symptoms can't fit into any system. This depression is a very subtle. There are two things which have to be very seriously looked in a man with a vague, man or a woman with a vague symptom. One of them is hypothyroidism, which can also worsen depression. And other is a depression, which may be intrinsic. Some families have depression as a problem. or it can be extrinsic due to some secondary factors. Next slide, please. So we pay a lot of attention the cognitive function in type 2 diabetes, mild neurocognitive dysfunction, secondary to diabetes on daily living is the observation that the diabetes are as twice as likely to have depression. Mild neurological problems can be more depressed. Type 2 diabetes have increased incidence of Alzheimer's disease and increased incidence of vascular dementia. Impaired glucose tolerance without diabetes is also so. Even pre-diabetic people who are not pakka diabetics labeled, but pre-diabetic or even gestational diabetic people can have subclinical depression. Next slide. Next slide, please. Yeah. Now, cognitive dysfunction patient type diabetes, almost 17% type 2 have moderate to severe deficit, 11% type 2 have cognitive impairment, 14% had a depression. HbA1c more than 4 times more have a cognitive impairment. Patients on oral diabetic medication had a similar scores of general tests for cognitive as subjects without diabetes. Next slide. Now, Accord studies mind neither intensive glycemic control nor BP control prevent a decline in brain functions. Intensive glycemic control increase the risk of hypoglycemia. Remember, the intensive diabetic programs, which was DCCT and other, have opened our eyes that hypoglycemia is a bigger risk for developing dementia. Swedish National Diabetes Registry, HbA1c more than 10% increase the rate of dementia. HbA1c less than 6.7 have no risk of dementia. But it is not universally true. Next slide, please. Glycemic control and cognitive. Now, obviously, cognitive dysfunction higher will have more chances, higher the HbA1c, more chances of cognitive dysfunction. So directly related to HbA1c. So you should try to bring down HbA1c below 7.5 ideally to reduce the cognitive dysfunctions. Next slide, please. Now glucose variable GV also, a lot of people have blood sugar fasting 100, post lunch 300, evening 60, night 150. So this GV, glycemic variability, is a bigger risk again. Rather than if a person having a sustained blood sugar of 160 to 200, which is ideal, or even 225 all the time, but no GV, glycemic variability, which is picked up by CGMS, GV has a higher risk of dementia. Next slide, please. Hypoglycemia is one major cognitive dysfunction related problem. Repetitive episodes of moderate to severe hypo have been implicated as one possible cognitive dysfunction. Acute hypoglycemia episode associated with impaired immediate verbal memory. People don't remember what has happened. After an acute attack of hypoglycemia, they have a dementia or they have a retrograde amnesia, like head injury. Immediate visual memory, working memory, delayed memory, visual motor skills, visual spatial skills, and global cognitive dysfunction. So hypoglycemia is a major risk, and nocturnal hypoglycemia, which occurs without your attention, the sleep is disturbed. He has obstructive sleep apnea. He may have atrial fibrillation during an episode of obstructive sleep apnea, and these people are more vulnerable to develop dementia. Next slide, please. So it's a very complex problem. Now, the pathophysiology is very complex. High fuel, low fuel, high metabolites, low metabolites, all impair, and there are multiple cascades of metabolic, hormonal, and rheological disorders because of hyperinsulinemia and insulin resistance. And normally, Indians are insulin resistant subjects. The insulin is produced but does not act as the target. There is a hyperinsulinemia and there is high sugar. And therefore, insulin deficiency, other mechanisms become trigger of the cognitive impairment. Next slide. This is a little complex slide. We'll realize the pathophysiology of cognitive dysfunction, diabetes, hyperglycemia induced end organ damage or a microvascular disease, insulin resistance, absence of C-peptide, absence of ApoE E4LL, and hypoglycemia all cause cognitive dysfunction in type 2 diabetes. Next slide. Now, this is the mechanism which is rather complex. Is the brain pathology is mixed, vascular, and Alzheimer type. All can lead to dementia. There can be a macrovascular disease, microvascular disease, hyperglycemia, insulin resistance, all are operative to produce hypertension, obesity, dyslipidemia. They also contribute. Now there is a comorbidity medications and genetic predisposition. Genetically, some people are predisposed to these changes in chemistry of the brain. Next slide, please. Now, diabetes and Alzheimer's pathology is very complex. The normal problem is either there are plaques, there is too much of insulin, there is less insulin, insulin degrading enzymes are more, and there are multiple chemical cascades which can eventually cause Alzheimer's disease. Next slide, please. Now, clinical features. Affected behavior is memory loss, forget to monitor glucose, forget to take medications, forget to take insulin injection. Now, worse is the patient has forgotten whether he has taken injection or not. I always tell people if you have forgotten, do not take it. One day high sugar will not matter. But taking a second shot can be a disaster. So, disease frequency of self monitoring when caregivers are available, there is an alarm system, long acting formulation, decrease the frequency, decrease the number of injection insulins, involve caregivers, choose supervised exercise program. Some people do exercise for the want of it. Some people do it exercise in a competitive spirit. They're going for a walk and they are 70-year-old and they see a 35-year-old girl walking very fast across them. They try to chase her. Now, this is a competitive exercise which is unfamiliar. That can 100% bring down the blood sugar and the person can tumble and fall. And a fracture neck femur is very common if you do unaccustomed running or jogging. Avoid labels as non-compliant. Make small changes at a time. When the patient comes to you, don't make major changes. Don't increase the dose too much or decrease the dose. Next slide. Now, obviously, this is what are the problems? Difficulty in stopping old behavior and starting new behavior. Difficulty with mental flexibility. Some people are just fixed. ये नहीं चलता, बरसों से हम करते आए, ये हमारा घर का ट्रेडिशन है, हम ये नहीं चेंज करेंगे. I will not change. Like asking somebody to change his diet completely is like asking him to change his culture. इसे बाकी घर में सब अलग अलग खाते हैं. I will not be able to do it. But you gradually talk to him. Avoid difficult tasks such as sliding scales. Have the simplicity is the key. The regime should be simple and safe. Safety first. In medicine, it is like do no harm. High blood sugar doesn't matter, but low blood sugar can kill the patient. Next slide. Next slide. Now, obviously, benefits of timely detection, potential benefits of timely detection, dementia, and other disease, maximize function, early treatment, better clinical management, greater independence, improved health-related outcomes, quality of life, and reduce healthcare cost and care burden. So, long-term good control of mind has got a better control of diabetes, and it's a cost-effective increasing the quality of life of a diabetic patient. Next slide. So most important, you must pay attention. Assessment of cognitive functions with the diabetes, short screening test, cognitive assessment, mini-cog, mini-mental state. These are all formulas done by psychologists very effectively. Modalities of assessment are neurocognitive testing, evoke Revon's potential, EEG, MRI, fMRI, SPECT, and PET. But they are very effective only if the patient is really advanced. Early stages, you don't need all this fancy. Only a good psychological analysis and a detailed clinical examination by a diabetologist who is trained in these problems can solve about 80% of the problems. Next slide, please. Next slide. So therapeutic approaches, good control of diabetes obviously goes without saying. What is good for your brain, it is good for heart. But the effect of approach type 2 is controversial. The greater decline in cognitive impairment patients on anti-diabetic medications. Accord trial, no benefit from aggressive glucose control because of increased risk of hypoglycemia. So don't run after blood sugar too much and too frequently. Have some flexibility. Keep a little moderate control if you want to avoid injuries due to cognitive dysfunction. Next slide. So obviously, GLP and IR are the treatment are now accepted. Next slide. Conclusion. Evidence from neurocognitive testing suggests that cognitive dysfunction should be listed amongst the many complications of diabetes, along with retinopathy, neuropathy, and nephropathy, and CVS abnormality. Changes in cerebral structure and function in diabetes is related to hyperglycemia induced end organ damage, macrovascular disease, hypoglycemia, insulin resistance, and amyloid lesions may play a role in some patients. Greater understanding of natural history of diabetes and the complications of this disease and the mechanisms responsible for its development will continue to advance as the biochemical and imaging modalities continue to evolve. Our knowledge will keep on increasing. They say the knowledge increases in arithmetic progression, but ignorance increases in geometrical progression. The more you know, the lesser you know. If somebody asks me, Dr. Baraskar, which subject you know the best? I don't know, I said. Which subject you don't know at all? I said diabetology. So this is what I say. As you become more and more specialist in that branch, you realize there's a lot to learn more. And at the moment, we are just scratching superficially. Thank you very much for your patient hearing.
Thank you, sir. Thank you so much for the beautiful presentation. Now, can I take a few questions from the audiences?
Please.
Let me see what are the questions that have come. So the first question is, how does chronic hyperglycemia contribute to the development of cognitive dysfunction in diabetic patients?
This question is asked me, which is the sum total of what I talked. So basically, cognitive dysfunction set in because of the chemistry of the brain is affected. Either there is too much of fuel, hyperglycemia, or there is a too many times frequently low fuel, too many hypoglycemias, particularly nocturnal hypoglycemias, and hypoglycemias which are due to aggressive insulin therapy or wrong choice of the drug. Some oral hypoglycemic agent have a continuous action. And please remember, if the diabetes is controlled very aggressively and nicely, if a patient with a blood sugar who's have fasting 200 and post lunch 300, he starts coming to you with the blood sugar 80 fasting and post lunch 140. Don't pat your back. Do his thorough renal functions. Because I tell you, today in type 2 diabetes, we see a lot of early onset nephropathy. And what does nephropathy do? It does not clear the insulin from the kidneys. And the half-life of insulin increases. If the same drug, which has have a span of peak action of 2 hours and plateau action of 8 to 10 hours, the actions are delayed. The same sulfur, particularly sulfonylurea, are more notorious to produce nocturnal hypoglycemia if this trait is not forgotten. That hypoglycemia is a cause of and as a result of uncontrolled diabetes. 1 minute. अनिता मी तुला 2 मिनिटांनी फोन करू मी ओके मी नंतर ओके 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 चा बाय अनिता काम झालं पुण्याचं या so
Right, sir.
basically I have to give a word of caution when you have got insulin and the powerful drugs which are very ultra short acting and ultra long acting, analogs particularly. They play havoc many times. And particularly if you don't know this fact, that do a thorough renal function. Normal creatinine does not mean the renal function is completely normal. You have to do creatinine clearance test or EGFR by calculations or by actually method. See for urine albumin test. If the nephropathy is ruled out, borderline nephropathy, you can alter the dose. Borderline nephropathy, you can avoid long-acting sulfonylureas. But this fact has to be kept in mind that these people don't have hypertension or they don't have edema of the feet, they don't have microproteinuria, but they have early nephropathy. Keep that in mind if the blood sugar is suddenly started behaving very well, or patient does unnecessarily some kind of intermittent fasting. There's a lot of fat about intermittent or ketogenic diet without any supervision or without any, rational person guiding them. And they suddenly go into hypoglycemia. And what happens? Hypoglycemia can occur in the evening. A person's PP sugar is little high, so the morning dose is increased. At 4 o'clock, when he's on a scooter in a Bombay traffic jam, he falls down because of blood sugar 60. So this has to be kept in mind. I hope this answers your query.
Right, sir. Thank you, sir. Thank you so much for answering this query. We'll take two more questions. The next question is, are there any lifestyle modifications or non-pharmacological strategies you recommend for improving cognitive outcomes in individuals with diabetes?
I think a simple lacto-vegetarian diet, we should not be much different from you. Avoid omega-6 fatty acids like safflower oil and oily food like bhajia, pakoda, potato vadas. Eat simple food. Take 2 teaspoonful of either rice bran oil or asli ghee, but not more than 2 teaspoonful, or 2 teaspoonful of carnel, cobra. But don't take deep fried food, samosas, vada, bhajias. Once in a while you can take it, but it should not be a regular affair like gathia. A lot of patients of mine, gathia is a normal constituent of their breakfast, and that should be avoided. Deep fried food.
Right, sir. Thank you so much for your suggestion. The last question for today. What role do glycemic control and fluctuations in glucose level play in the progression of diabetes-related cognitive dysfunction?
See, fluctuations of blood sugar will always change the chemistry of brain. Brain is one organ. Remember that. People did not know that brain plays a major about the 12 areas which intervenes today are possible. In fact, bromocriptine was tried, but it did not succeed. The brain also plays a major role like liver, muscle, pancreas, and kidney. Brain also plays an important role in management of diabetes. People realize the importance of brain so late. Brain is a very important organ. People realize that. And all the IQ testing and everything in early childhood aptitude studies, they realize if the child is well fed, well nourished, he does 6 to 7 hours of studies and at least 8 hours of sleep and at least 2 hours of physical fitness exercise in the playground and not at home. And mobile time as well as computer time should be restricted to only 2 hours a day. If that happens, he becomes a smart, intelligent, and a robust young man. And we need such people. India has the highest number of young population, but the young population should be fit. Then only this country has a great future.
Thank you, sir. Very well said. So with that, we would like to conclude the session for today. But before that, I would like to thank you for taking out your time and sharing such valuable insights for giving us your invaluable time, sir. Thank you so much.
Thank you so much.
Thanks to all the audiences for joining with us.
Thank you.
Thank you so much, sir. Have a good day ahead.
Bye-bye.
Bye, sir. Take care.